Hi everyone, thank you so much for coming. My name's Ruby. As Desiree mentioned, I'm a doctor who transitioned into research. I qualified about 7 years ago before working for a couple of years, leaving clinical medicine, doing a master's in psychology and ending up here in the world of medical education and XR, very wiggly path. I have to say I'm not used to presenting to a room of tech experts and industry experts, so feeling a little nervous, so go easy. I'm used to a room of academics, and I thought that there couldn't be anything more intimidating, but I think I might have found it, so we'll see what happens. So I'm just going to talk about the project we've been working on, the PhD project, simulation more broadly, and what we've been doing with GigXR, developing an application called HoloScenarios. So I'm very, very lucky to work with a team of interdisciplinary academics, clinicians, developers, educators, learning scientists, and with them we collaborate on this project. So part of my time is spent at Cambridge University Hospitals, and I work at the simulation centre there. That's a picture of a high-fidelity mannequin, which I'll talk about in a minute. And then we also, as part of the PhD Knowledge Exchange, collaborate with GigXR. They're a mixed reality company who are based in the States, and they develop mixed reality technology enhanced simulation for medical training. Most of my time is spent being a nerd at the Faculty of Education, where I think about the underlying educational theory underpinning the development of these applications, but also think about how we research and evaluate these technologies to form a robust evidence base supporting their use, which is what I think is extremely important. So if you're not aware of medical simulation, this is the view that a medical student often has when they're training. A busy ED room. It's quite stressful and it's quite hard to get involved. I spent a lot of my time here peeking over, trying not to get in the way. And then one day you go from being a medical student and suddenly you're a doctor who has to manage these situations. And we need to think about how we bridge that gap for medical students. And one of the ways is simulation, which is essentially just the approximation of reality using a device, a tool, an actor, any modality to help students practice high-risk, low-frequency scenarios in what is a safe-to-fail environment. And as I mentioned earlier, at Cambridge University, we have this high-tech mannequin, and this is computerized to provide physiological feedback to our students, and with that they can run acute medical scenarios in real time. And although this is great, and some people might consider this the gold standard, it's not readily available to everybody, it's expensive and it's quite resource heavy, meaning that even across the UK and globally, not everyone has the same access to simulation-based learning. So with that, we've collaborated with GigXR to develop an alternative, and this is a mixed reality solution which uses holographic overlays to create acute medical scenarios which run in real time and can be interacted with by our students. I'll talk about that in a bit more detail later, but I just wanted to talk more broadly about XR and medical education from the kind of academic point of view. And the great news is that publications in this area are increasing and on the rise massively, which makes me very excited and very happy. However, this is mainly centred around the use of VR in surgical education, and the use of mixed reality in non-surgical education is still an area academically in its infancy, which is partly why we chose to sort of enter into this field. So at the start of my PhD, I had a look at the existing evidence base surrounding the use of mixed reality technology in medical education, more specifically non-surgical education. And we found three main gaps that we're aiming to at least begin to address in this project. One of the gaps was that commonly XR-enhanced training tools in medical education aren't always based on robust theoretical frameworks and learning outcomes. And this means that it makes it very difficult to compare two theoretically based teaching tools. And it also means that further down the line, once we analyse the technology and want to do something like a realist synthesis, it's very difficult to understand why and how something works. Similarly, there's a lot of heterogeneity surrounding how outcomes are measured in research of this nature, exploring XR-enhanced simulation, which means that it's very hard to build a cumulative evidence base underpinning its use. And often assessment tools that we're using as a proxy to measure outcomes aren't always measuring what we think they're measuring. And finally, there's a lack of experimental research comparing XR-enhanced simulation or mixed reality-enhanced simulation more specifically with the current, what we might say, gold standard or more established training techniques such as high-fidelity simulation mannequins. So as I said, we're starting to address these gaps Obviously, it's not going to happen in one PhD, but we're on the way, and this is kind of where our focus is throughout this project. So as I mentioned, we were lucky enough to collaborate with GigXR on the development of the application HoloScenarios. And HoloScenarios, as I said, uses holographic overlays to run these acute medical scenarios in real time that students can interact with to practice running these high-risk situations in a safe environment. Multiple students can join at once, and you can also join remotely, meaning that you're not required to be in a purpose-built sim centre or all in the same space. The first thing we did in developing this was, aside from the tech, is we chose our learning outcomes. And I think this is the most important part of developing this technology. We mapped 2 curriculums from UK medical schools and the UK Foundation curriculum, and from that picked learning outcomes that are required to manage an acutely deteriorating patient, the sort of skills, both technical and non-technical skill, that you would expect a doctor to have when managing these kind of scenarios. And from there, we built our scenarios. It was also important to think about exactly what are we trying to achieve with simulation-based learning before delving into the development. And ultimately, what you want to do with a simulation is take the student out of this complex environment, break down a more complex situation, immerse them in this scenario. Then, through a kind of social constructivist approach, students then build upon new knowledge through interacting with the environment and hopefully acquire a set of targeted technical or non-technical skills, which they can then repeat with increasing levels of complexity before, we hope, integrating these back into a clinical setting with the overall aim of improving patient safety. And this aligns quite well with what we call Kolb's experiential learning cycle, which is a series of steps that a student goes through when they learn, from this concrete experience, so the simulation itself that they're engaged in, to a period of facilitation where they reflect on what they've done, develop new theories, think about how they might apply this to their future practice, and then experiment, so run it again with these newly updated mental models. So the first thing we needed to do was create this really good concrete experience in mixed reality. And I think there's 2 key parts of this. One is creating great visuals, so everything looks particularly lifelike and creating a very lifelike experience for students, but also creating a very interactive scenario. We worked very closely with artists to make sure that visually the patient appeared as they should and made sure that they exhibited signs and symptoms of respiratory distress that you expect a patient to see. But also we thought about the more core features that you might expect to see. So we created branch scenarios whereby our virtual mixed reality patient improves or deteriorates depending on the actions that the students take. So for example, our patient with asthma continues to deteriorate if the student doesn't provide the correct treatment. And this is essentially how you might expect a patient to respond in real life. We also uploaded lots of patient data that the student has to analyse, and the hope is that they can then interact with this data and synthesise it to help assist their clinical decision-making in real time. Finally, in terms of the decisions that the student had to make, we made sure that these were nuanced and as close to life as possible, encouraging them not just to click through a series of options, but really think about the decisions they were making. And we made sure that these aligned with the sort of decisions that they would have to be making in actual clinical practice one day. In terms of facilitation, we've created facilitators' guides to help people running these scenarios, and this includes some advice on how to run them and some staged instructional support that you can also offer students throughout the scenarios to help aid the facilitation process, whereby this reflective observation and abstract conceptualization takes place. I think this active experimentation that I talked about, whereby students can go back and practice what they've done and learned, particularly lends itself well to mixed reality because we can tailor scenarios, you can join remotely, and it has that element potentially of increased accessibility. So with that, we create segmented scenarios that students can go back to and run different stages of. And we also created different levels of complexity, whereby the student can try different levels which get harder each time depending on what they've learned and the levels of experience that they have. And this was ultimately our result. This is a short clip of HoloScenarios, which I'll let you watch with 2 doctors practicing the anaphylaxis scenario.
I think so. She's wheezy, and if you ask me, she's becoming, you can see the wheels over her neck. Yeah? Yeah. She's becoming red.
Yeah, I think this is anaphylaxis.
Looks like some kind of a reaction. Increase the oxygen a little. I'll make it 12 liters.
Okay, well done. That's a good idea.
Yeah.
Excellent. And then others let us know once you...
Alright, adrenaline is dispatched.
Yep.
Okay.
Yep, I've got the syringe.
So that's just a short clip of what the student sees and the sort of scenarios that they interact with. The second theory that we've based this upon is cognitive load theory. And this is particularly relevant to simulations because simulations provide the opportunity to modulate the amount of cognitive load that we place upon students. Cognitive load theory essentially stipulates that we have a limited amount of information that we can process from our working memory to our long-term memory, meaning that if we overwhelm students by overwhelming them with too much information or presenting information in a way that's not easy to digest, it means they become unable to process new information to their long-term memory, a bit like after a long meeting why you can't process more information after hours of discussing new ideas. So we've taken advantage of that and the fact that we can tailor these scenarios to help modulate the amount of cognitive load that's placed upon students. And as I mentioned earlier, we have different paths of difficulty for these scenarios. We've also built prompts and scaffolds into the scenarios themselves and given ideas for instructional support that the facilitators can offer throughout the scenarios for students who might be less experienced to help lower and reduce the amount of cognitive load that's placed on our students. They can then go back and withdraw this instructional support as they become more experienced. So the next phase of this project is thinking about how we evaluate these kind of technologies. And this is kind of the crux of the PhD that I'm doing. It's a little bit beyond the scope of today to talk about all the methodology and the protocol and everything, and it might get a bit lengthy for you. If you want to talk about that in more detail, please come and find me at the end, and I'll happily chat about it for many hours. So we go back to our theoretical framework, and this helped me think about what questions we need to ask with these kind of applications. So ultimately, we know we want to target a set of technical and non-technical skills, which we expect these training applications to deliver, and we expect them to be at least as good as what we already have in providing students with those skills. We also hope that they can integrate these skills into a clinical environment. So we want to see their behavioural change when managing a clinical environment. And it's these questions that we need to be thinking about and formulating when designing our research. I mentioned earlier that the way that outcomes is measured in simulation-based research is very heterogeneous. So we've made the decision to target these set of technical and non-technical skills that we've derived from the curriculum and have chosen existing validated assessment tools to assess these, which we'll be running our own validation on as well. It's important that maybe we have a pause on developing new assessment tools to try and use what we've already got and validate what we've already got to help build that cumulative evidence base. We're also deciding to use objective assessment measures, so we're using observational tools whereby an assessor observes a student performing a set of skills and then scores them appropriately, because historically there's been a reliance on self-report measures, which are good but sometimes have bias and don't always give us the full picture of how well a technology works. So in terms of the design, we're running an RCT experimental study, which essentially compares our mixed reality enhanced simulation HoloScenarios with the same scenarios run on a high fidelity mannequin, with just the systematic changing of the training modality. What will happen is we've already run one session. We'll run a pre-test whereby students, using an actor, run an acute medical scenario which targets the learning outcomes we want to target. This will be observed by an independent assessor and marked using our validated checklist. They'll then in the afternoon be randomised into one of two groups and run the same scenarios in parallel, either in mixed reality or high fidelity, before undergoing a post-test scenario where they run a different but matched in complexity acute medical scenario, which is also observed and assessed by a trained assessor using the same assessment tool. This hopes to show us a change in skill from baseline to after training, which we can then compare between the two groups. So the objectives of this, because the research is in its infancy, we'll be able to do some cautious hypothesis testing. But more importantly, what we're looking to do is verify the integrity of this study protocol and understand the feasibility and the practicality of running this kind of research in a national health system with students when so many different confounding and human factors are going on, with a hope that if it works, we can learn from lessons and then potentially utilise this as a blueprint for evaluating future MR, even VR, enhanced simulated scenarios. So ultimately, the aims of this PhD are to develop, or were to develop, these XR scenarios based on robust theoretical frameworks, foster this interdisciplinary collaboration and learn from that collaboration to think about how we can foster future collaboration, evaluate existing outcome measures to help build this cumulative evidence base, and verify the integrity of a novel pilot RCT study protocol, which could potentially provide a blueprint for evaluating future technologies, with the hope that in the future we might even be able to scale this up, utilise it for other technologies, and maybe even get funding to do so. So I don't think it would be a presentation in 2023 without talking about AI. So this is a added element and a project that I worked on with GigXR whilst doing an internship with them over the summer. And we've worked on integrating conversational AI into the system with a hope that one day our virtual patients will be able to speak to us. We utilise large language models to allow us to converse with the holographic patients and to have lifelike and realistic conversations, which can be tailored to the students' needs. This opens up a whole new avenue for increasing the fidelity of the scenarios, but also training students around more complex non-technical skills as well. And I have a short demo of this run by one of the guys at GigXR, just to show you how it might look in the future. This is hoped to be integrated with our holographic patients, so in the future we can also have a conversation with them.
Can you please help me?
I should be able to. Can you tell me a little bit about when you started having troubles breathing?
It started about an hour ago. I had been feeling unwell with a cold before that, but not breathless. Then suddenly, it felt like I couldn't get a proper breath in.
So as you can see, Sandra's telling me a little bit more about her background, and I can continue to dive in.
And this will be integrated into the
I can ask you
applications.
questions about her personal life, about the situation. So let's just ask some common things about her. So, hey Sandra, what hobbies do you like to do?
I enjoy drawing and photography.
So each of her patients are created as a
And that is everything. I'd like to acknowledge my supervisors at Cambridge University and the clinicians that have helped me develop this technology and work on the research, and of course GigXR, with whom we've collaborated with for this project.
A round of applause, please, to Dr.
And now, time for the Q&A. So please, who has a question? Perfect.
It's quite impressive to see that we're witnessing the future of medical intervention and maybe medical education.
Hopefully.
So please.
Thank you. Hi, Dan. I just have a question around how the students themselves took to using this technology, especially if they were using it for the first time, and how did that factor into the research itself? Because what did the learning curve look like for them to get to a place where proficiency was, okay, everyone's proficient, everyone understands how to use the technology. Now we can start understanding whether it actually, helps or not.
That's a very good question, which I probably should have included. So we ran 2 rounds of usability testing prior to the research, because the main thing that I wanted to make sure was that we weren't impeded by usability issues, which could potentially just totally disrupt our data. So there was variation in terms of how quickly students took to the scenarios, and I couldn't find any particular pattern in how well students adopted the mixed reality. Some picked it up very quickly and some took a little bit more time. The main limitation that I found was the slightly more narrow field of view on the HoloLens, which meant that it's guided by eye tracking, and commonly students would look away from what they were moving and then drop the item under the bed and we'd be scooping it off the floor. So that's something that we had to tell the students to do. We also mitigated this by having an assistant in the scenarios with them, which we'd also do for high fidelity simulation as well, to make sure the 2 scenarios were matched. And they could always take over as well if the students got stuck, to make sure that any data we got wasn't obstructed by potential usability problems as well. But it's a very good question and something that I think I'd like to explore more in the future if I have the scope to.
Thank you. Any other question, please?
My name is Timon. I was wondering, what were some of the reasons why you chose to go with like AR or mixed reality over something like virtual reality?
There are a couple of reasons. I think One was to do with the fact that it's quite an unexplored domain. Secondly, I think the see-through nature of the lens makes it easier to do the team-based scenarios, and often you're managing these kind of scenarios with other clinicians as well. So because of that, it's easier for students to join as a group and interact with each other and engage in the dialogues that are quite important for running these scenarios. And the other reason I think was slightly to do with the tolerance of actually being in mixed reality, trying to overcome some of the barriers that students might have in virtual reality, such as cyber sickness and things like that, because we found the mixed reality headset is generally quite well tolerated for longer periods of time.
All right. Any other question? But by the way, are you satisfied with the answer? Did it respond to your question? All right, perfect. Any other question, please? Feel free, we still have some time. And I think that it's quite exciting to, literally witness the use case of extended reality in such a complex, and not just academic, but in future, practical application. I know we have a medical professional also in the audience, so I'm looking forward to hear your question.
Hi Ruby, thank you for your talk. I was just wondering, did you ever try to use the system with medical doctors above the age of 40, and how did they respond to it? I'm from the same field, so I have a reason for that question.
Ah, good.
I think I can just quickly add the background from it is, about cultural resistance or simply change management standpoint, because this is complex and sometimes, you know the resistance that you probably experience in your work field. So please go ahead.
It's a good question. We've tried with some people over age of 40, and similar with the students, there was varied responses in terms of the usability. I'm not sure if you mean in terms of the usability or the acceptance or both. Acceptance varies hugely between medics depending on their backgrounds, their views on this technology. Often I try and make it very clear that we're trying to be educationalist-led and medic-led. And for those, we do have some resistance, understandably, because it's quite disruptive and it's quite a change. But I think the bottom line is these changes are happening anyway, which is what I tell the medics and the educationalists that might be feeling like they have some obstruction to it. So this is the time for them to then get involved and steer this technology in a direction that they want to, for the use case that they want. And I do strongly believe that we should have medics, whether they're resistant or not, and educationalists involved right from the beginning, right from the point of conception of this technology. And that's kind of what I've told them, that regardless of how they feel about it, it's probably going to happen. So the best thing they can do is get involved, try and steer it in the direction that they believe it should be going in. And I think I also try to iterate the fact that we are trying to build this evidence base surrounding this technology, and we're taking that extremely seriously to make sure that this technology is fit for purpose. And I think that's essentially the most important thing when designing this, because it's lives at stake and it's students' well-being at stake as well. So I do understand reservations.
So you two should definitely get on a talk afterwards to see how you can help each other. We have time for last question. But don't worry, you can actually continue discussion after the session, in any case.
Thanks very much for the interesting presentation. I'm just wondering, with the dummy, you'll have a lot of haptics that you're not going to get with the HoloScenarios. Have you evaluated how that might affect the learning outcomes?
Yeah, it's a good question. And I think to take this technology to the next level, haptics, and alongside AI probably, is going to be the next steps. I think for that reason, the outcomes that we have been focusing on primarily surround clinical decision-making rather than actual procedural outcomes, because I do understand that actually without the haptic feedback, I think procedural training for medical skill would lose a lot of its value and its richness. So in terms of the skills that we're training, we're kind of picking skills that don't rely on haptic feedback so much. But I do agree with things like surgical training, haptics would be an extremely important part. With the high-fidelity mannequin, we're not really testing, although there's a mannequin there, we're not really testing students' abilities to do procedures on the mannequin. So often there's a nurse with them and they kind of verbalise what they might like in terms of investigations or management, and the nurse or the sim technician performs them for them. So we've tried to keep that standardised between the groups. But I do think there are certain things that haptics will require in the future, and that's the next level, I think, for XR.
Ruby, before you end, can you tell people where they can continue discussion with you after this talk?
Yeah, I'll be here, I think.
All right.
And then I'll be in the main hall and
Okay.
around later as well. I don't think I put my email on the slides. If you want to contact me, it's raw83@cam.ac.uk if you have any further questions, or I think I've got a LinkedIn page on my AWE page as well.
Please, a round of applause for Ruby Woodward from the University of Cambridge.